Thanks for joining us for part two of our three-part interview series with Brendan Keeler. In case you missed part one, be sure to check it out to learn more about Brendan's experience at Epic, Epic's company culture, the evolution of interoperability, and stories about Epic's CEO, Judy Faulkner. In part two of the series, we do a really deep dive into healthcare interoperability. Brendan has a wide-ranging experience with healthcare interoperability and is one of the foremost experts on what's possible and what's not when trying to share healthcare data. Plus, we cover nuances related to the regulatory landscape, including QHINs, TEFCA, APIs, and much more. We also talk about the costs of interoperability and different ways healthcare startups should approach healthcare data integration. Now, here's part two of our conversation with Brendan Keeler. Well, let's dive into interop. And this is where I'm going to embarrass myself, I think, to some degree. Where do you think we are on interop today? Like, what would you say, where are we at? What's possible today and can be done? And then what are we almost able to do?
Yeah, I mean, again, break it all out. Think about workflows between different healthcare organizational types. Between payers and providers, we have some workflows that are very highly digitized. So we're high on the interop scale, claims and eligibility. We have other things for payers and providers. So again, you have to get down to like the workflow level,
Mhm.
like prior authorization, like clinical data exchange between providers and payers, which is a hot button topic the past
Yeah,
couple of
it,
months.
it all goes with
Um,
ROIs and stuff. It's crazy that there's not a standard for that. Yeah.
Right, right. Well, right now we're in this phase where it's like we have Datavan and Moxie, we have TEFCA operations, we have Particle Dispute, which is focused around payer provider data exchange. We have Vim. All these players right now have that problem set sort of in the middle, but it's not homogeneous, it's not ubiquitous. Um, and that leads to a lot, like that's why we have some of these tensions there. We have other problem sets, well, like prior auth is another, you know, payer provider data exchange. And while there are a few solutions, it's really point to point between a payer and a provider. Like, Providence and have like set it up. But like you would want that at scale for all payers to all providers to all their payers to
Is
have
that
this.
on the horizon though? I agree with you, right? I think there are point to points to solve it a little bit. It is e-prior auth on the horizon, or is it still just a pipe dream?
So we've seen very like the private industry is allowed to solve these problems. The government would love it if private industry solved and create the networks that are necessary for a national scale to solve these problems. And EPA, while there are point to point and like some one-off like to point at, hasn't really been solved. You see a lot of AI for that reason. You see a lot of AI solutions gravitating towards it. To anytime there's like a lot of like manual work, people who are in love with the new AI revolution say, "I have AI. What can I solve?" And they gravitate towards extremely manual problems, which is a good thesis, but also non-creative, right? Like usually start with problem set and find tools to solve it is a good pattern.
You know the
But
craziest one I heard for that? I
what's
was
that?
talking to this company at HIMSS, and he was like, "Yeah, I forgot what they needed to call the insurance company for." But anyway, they had to, there was this workflow that the provider had to call the insurance company to get the data and then bring it back. So that I can't remember exactly what it was. It wasn't prior auth, but it's something similar, right? Where they had to get some verification or something. He's
Yeah.
like, "Dude, we finally just said screw it. We're going to create an AI bot to call the insurance company." So now they're doing tens of thousands of calls using a bot to, which had to provide the birth date and the name and whatever the information to get some reply back. And then but here's, he used it. He was smart. He said, "Yeah, now they come to us and they're like, hey, why are you calling us so much? Like, why don't you use our API?" And he's like, "I wanted to, and you wouldn't give it to me." And so that's why we had to build this bot. And they're like, "Oh, well, use our API." And he said, they wanted to give it to him for free. And he said, "I don't want it for free." He said, "I want to pay you for it." He said, "Because if I get it for free, you can cut me off at any time. But he said, if I pay for it, then you'll keep supporting it because it's a revenue stream." But I was like, wow, and it's the epitome of the misery we're doing right now. Like,
You just hit the narrative arc with exactly where I was going, which is these AI, everything's manual. All this horde of like YC, Y Combinator, Silicon Valley startups are descending upon them So like payers are being assaulted with phone calls, providers being assaulted with phone calls, because piggybacking on that ubiquitous network or any ubiquitous network becomes very trivially easy with AI. And so that pressure is a forcing function for actual digitization. So it's like actually kind of good. It solves the problem, solves, right? Like the AI bots
Yeah.
get the job done, but in an inefficient way, potentially.
I think he said it was 10 cents for him to do it on a phone call versus he estimated for the person it was $1.25 or something like that.
Right. We're improving. And then it forces this forcing function where pairs go, shit, I don't want to have battle of the bots, right? Like a bot answering and a bot calling and that sort of thing. BattleBots was a very 2000s era TV show that we don't necessarily need
Even live
repeating.
in Vegas, you can see it live, but
Okay, at Health, I'll be at Health. Anyone want to meet up there?
we'll
Give
do
a
a little
holler.
meetup, go to BattleBots together.
Yeah, but it forces us towards it's a market pressure forcing us towards digitizing different workflows, which is good. In particular, our product manager for the US, the ASTP, and the CMS have said this is a priority to fix. Prior authorization. They've said that we're pulling this forward. And so in CMS regulation and associated certification regulation, HTI2, we see electronic prior auth, a standard called Da Vinci, a FHIR implementation guide, be defined and so need to be rolled out in the next couple of years. And a bunch of states are latching onto that and saying, let's go even faster. Let's not wait till 2028 or whatever. Let's go faster. Let's go faster, like Washington. And so yeah, it's on the horizon. It will be the technical term is messy shit show because it is a complex workflow, right? A prior authorization is I need to understand the document template. What information do I need to submit for each procedure that I want to prescribe for each payer? So a lot of possibilities. Then I need to somehow pull out of my EHR all those discrete data points, which may or may not be discrete, right? They may be buried in a lab PDF or something. And then I need to send the prior auth over, which is the easy part. And so, like, if you think about the fractal possibilities that come out of that, number of payers times number of procedures times number of plans, right? Like, you get a lot of possibilities and data points that need to be pulled. So it's going to be really, really difficult. I expect what we see it is a messy time as it's deployed to start. It settles in for the top procedures, the most common ones, and makes it more efficient. And then we see longer tail procedures and things like that over time. But it's going to force a data quality on providers that I don't know that they're ready for, and a lot of data standards troubleshooting because this exchange is significantly more complex of a interaction than we've ever seen before. It uses FHIR capabilities and standards that very few people are familiar with yet, like CDS hooks and CQL. And so those are very technical, not for this audience, but it does pull us, drag us into the future for this particular workflow.
It's interesting you said the providers may have a challenge with it and the quality of data. I don't think you're wrong. I would have thought more on the payer side that it almost creates a haves and have nots, right? Because there's a lot of smaller payers. Can they really do it? I don't know. And does that mean they're just going to sell out and we're going to end up with three payers or whatever, which in some areas I think we already have. But
Great regulatory burden, regardless of industry, adversely affects startups, small companies, small organizations who have less resources to shoulder the burden. There's artful regulation that scales as the bigger you get. This is
sure.
not one of them, right? Like this is
And
so
it
like
probably shouldn't be, right?
yeah,
Like,
yeah, but like the other there's two outs, right? Like merger, consolidate, like go bankrupt. Like sure, those are possibilities. The other is, and this is good, maybe good if depending on your viewpoint, is that it puts a pressure to have fewer prior auths. If you have fewer prior auths, you need less of the encoding of your payer logic, tribal knowledge into actual codified programmatic responses. So if you have 100 procedures versus 10,000 that need prior auth, you reduce that burden. And so the unstated pressure here without saying we cannot do prior auths or like strong mandates is the government's putting a pressure on payers to limit the amount of procedural prior auths that they need. So I think that's good. I think it's a forcing function for them to be smart, right? Like prior auths are an unfortunate function of our healthcare system to limit costs. Um, I am not deep enough in the weeds, nor am I a provider enough to call out when they're right or wrong. But I do think having pressures that aren't like really clumsy, you can only have 500 procedures that can be prior auth, and something like this that like, yeah, the more prior auth you do, the more work you're going to have to do. Um, that feels good to me. That feels like a good compromise.
Yeah, I mean, it's a beautifully optimistic view of what ePrior auth could do, which is to say, hey, why don't you do what you should have done forever ago and see which prior auths really matter?
Yeah,
Which ones
you're
are.
gonna find optimism in everything I say about this stuff because that's just like kind of who I am. And I don't think it's like overly rosy. I think it's pragmatic to say most of these things are a forcing function to get to an outcome. There are adverse consequences, but like in this case, the adverse consequence is one that is not good, I think.
Yeah. So I want to talk about the mix of interoperability, data sharing options that are there, right? We have APIs, we have HL7, we have Fire, we have X12, we have, we have enough standards. I don't know. That's a different discussion. But so my question for you is how should a startup company, let's say a startup, maybe any vendor that wants to integrate with the EHR, you know this world as well as anyone out there. And I look at this world and and when I'm talking to startups, a lot of them come to me and they're like, John, how do we integrate? What do we need to do? And my question is, well, first of all, what data do you need to share? And then second of all, and do you need to write back and all of this, right? Like, how do you answer the startup question of I want to integrate with the EHR? Because to me, it's such a complex one. And unfortunately, I would say a huge portion of the time when they say they want to integrate, I find out that EHR doesn't have the API they need to integrate with that data because it's not available. What do you see in that regard? Do you see a lot of them? They don't need, the data is there and they just don't understand the framework of how they need to integrate with that company. I'd love to hear your thoughts on that.
Yeah, I mean, many, right? Like I have the whole blog that has broke down very various vertices, but like first thing to think about is what kind of digital health actor am I? Am I a business associate application? Do I sell to hospitals or providers
Mhm.
such that I sign a business associate agreement?
Yeah,
That's
I'd say
category one.
most do. And
Yeah. But like it's worth calling out because there's different tools available if you're a non-HIPAA app, right? You might use patient authorization to access data. If you're a provider, a tech-enabled provider like a One Medical or an Oak Street or anyone that employs providers, well, you have the rights as a provider. You can use interoperability networks and things like that. Um, so like there's different capabilities there. Most of the people asking this are saying, "Hey, I'm selling into a health system or a provider or a clinic, and how do I connect to the EHRs?" And so then the problem set becomes a function of workflow, right? Do they have they solidified their product well enough to define the full set of workflows that they need to accomplish? Because if they haven't, then it is impossible to tell which tools to use, right? Like any problem set, if you say, should I use a screwdriver or a hammer? I'm like, John, what are we doing? And so, like, if you can't describe it, if you can't say, hey, I'm doing analytics and I need a full pull of this table versus, hey, I'm a patient engagement app and I need to receive appointments, then you don't like looking at standards and backing your way into a product is folly, is the same as saying, do I use a Postgres database or MongoDB? Nobody would do that unless they know what they're building.
sure.
Um, and so workflow comes, and then you can define data flow. And in data flow, you're going to ignore the EHR for a second. You're going to say, what is my minimum viable integration, knowing that there'll be manual work to fill in the gaps, and what is my maximum? What is the ideal?
Mhm.
You break that into a couple of steps. First is enrollment. How do I get the relevant population to me, the application, which can range from the full every patient seen in the health system to a specific department, visits in a specific department, anytime an order is placed for something, um, when a lab result it fires off, like what is the criteria necessary to say to your app, hey, this is something that's relevant to me and I need to start doing something. So you have that enrollment step. That's often a push, the EHR pushing out to you via HL7v2 Um, Not really via Fire. Fire doesn't have that push mechanism yet. Or you polling, right? Like with an Athena Health or other EHRs, you might say, I'm going to ask it every 5 minutes if they have, the type of patients I'm looking for. So you do enrollment. You say, okay, I've got my patients, Brendan, John Lynn, like 1,500 other patients that meet the criteria for the start of my workflow. Then I supplement. I need other data. And that could be other data that's pushed to me over time and I just amass, or it could be data that I pull. Fire is very, very good for the pull, right? That supplementation step, I can go and I can pull the meds, I have this patient ID and I can pull the meds, the allergies, the things I need to get the full picture to do the workflow in the application that needs to be done. And then there's write back. I push data back into the EHR to finish the workflow or to do some interim step in the workflow. Oftentimes a PDF, sometimes discrete flow sheets or discrete values or a result of if it's an order initiated workflow. That core scoping is what we help with at HTD, not the plug,
Yeah,
but
no,
it's
it's good.
something that should be defined in a vacuum and it should be defined both in the minimum viable, which ideally could be zero. Like if you think you could sell your product with zero integration, Godspeed, go do that, get real users using it and figure out what you actually need. But if it's just the outbound feed, whatever, you should do the minimum viable to get sticky, to get real feedback, and then to do what you would do with any product management, which is use user feedback to solve the next problem and tier your integration towards that ideal so that the work from the health system or the provider matches the work that you'll do. And so that's like data push and pull. The other aspect of data integration worth calling out is context synchronization. And so you have your app and it's sitting next to the EHR. If you have to log into both, that sucks. And so there's different levels of context synchronization that you can do. You can do single sign-on. So Smart on Fire is a technology there, but there's others where there's a button in Epic or whatever, and you click it, it launches, and then you're signed in. It just maintains it and provides other data. That's pretty cool, and it's ubiquitous because of health certified health IT requiring that capability of EHRs. You then have the next level, which is CDS hooks. And CDS hooks, clinical decision support hooks,
Mhm.
Epic has it. A few other EHRs are playing with it. It's going to be required in upcoming certified health IT regulation, most likely. In this workflow, when the user does certain things in Epic or Cerner or whatever, like open a patient or start to prescribe something or add a condition, it fires off to my app and gives me the chance to evaluate and say, do I want to tell the provider something in workflow?
Mhm.
And so you can say, hey, Dr. John, don't you want to go launch my app because this condition is relevant to this app? And so it's a cool new, like even more dynamic way of context synchronization and like workflow embedding to make the app feel seamless with the EHR, which because like there's more pressure on that. Whereas like 10 years ago, 15 years ago, you could just live in the side-by-side world. And there's even a level beyond that called Firecast that no one except for Epic is doing, as far as I know, where it just like passes back and forth events and context synchronization about every action in the EHR. And so that's a lot. I'm throwing a lot at you and I haven't stopped for
No,
breath for you to ask questions.
no.
But
No, I think this is, you described it perfectly, right? Everyone says, I just want to integrate. And you're like, okay, wait, what do you want to integrate? What data do you need? What was your workflow? I think that's a genius recommendation. I think the problem too that I've seen from many is that in so many APIs, be it Google Maps or Twilio or whatever, you sign up for the API, they give you some examples and you can integrate it, right? And you can test it and you can do everything that you want. And then you can go to a customer and say, hey, we've integrated, we can do this really cool function. But that's not how it feels like it works with the HR. I think it's probably the protection of the data, but I'd love to hear your thought. Like everyone that I've heard says, bring a customer to the table, say this is this is the use case we want to do, and then maybe we'll work with you to help you do it. Is that the right way, or am I misunderstanding? And there's a secret door that they should use to get into to be able to do the integration. It always feels like bring the customer and then we'll have a conversation. If you don't bring a customer, we have too many requests, right? I think that's what it feels like to me, is that they're like, we don't know who to work with. We have to trust that you're going to do it right. But if the customer approves you, I guess we'll do it. You know?
Right. I mean, so with that process of scoping, thinking about the why, the workflow, then the what, like what do I want to pass back and forth? What's my MVI, my minimum viable integration, and the ideal? You then have to go and say, how? How am I going to build this, right? And so you have to look at your customer base. If you don't have a pipeline of provider customers, you can go build Fire, you can go build HL7, you can take your best guess. You're gonna be guessing, and you can be wrong because the how is very disparate across EHRs. The how includes standards, Fire, HL7, flat files, proprietary APIs, all the spectrum of different capabilities and formats. That's one variable that the closer you get to knowing the EHRs in play, to having a customer, the better suited you are going to be able to write capability set. You
Sure.
can always guess. Two, tools like Redox, tools like Rhapsody, tools like Vim for mid-tier EHRs, NextHealth for dental EHRs, HealthJump for, again, that mid-tier EHRs. All these tools that you can use to simplify maybe that problem set of like disparate standards. Well, you kind of still want to know what your EHR mix is going to be like because they're different. They're different levels of proficiencies from those vendors and it changes your build buy equation. And so you like that aspect of how also includes app programs.
Mhm.
So historically, you're 100% right. You would go and there's no way to connect to the EHR without having a customer. And then you would go and test in their testing environment and you go live and go into production. Now, with the emergence of APIs and these things, you start to see different app programs from EHR vendors. So you have, the Cerner Code program, you have like eClinicalWorks Helo, Meditech Greenfield, Epic, formerly App Orchard, formerly App Market, now vendor services,
Mhm.
and a complex web of other programs and titles that we can unpack if we wanted to. Those are all different app programs that allow you to go to the EHR up front and get some level of support, some level of testing, some level of developer forum potentially, and maybe a sandbox, not for Epic, but for Cerner, for Athena, for some of the other EHRs, you can get a full user interface, whereas Epic, you just have what's called the test harness, which is you don't get access to hyperspace. And that gets into their weird views around intellectual property. Not weird, but like obsession over intellectual property to some degree.
Hmm. How would a organization that wants to integrate, because you're right, there's a plethora of options now, which is great. I mean, you were part of it at Redox, building out, you saw this problem. Like, I don't want to integrate with 17 different EHRs. I want to integrate with one and let me connect to them all. I think that's the Redox, perspective, right? And, how do you make that decision as a company? I should just integrate directly with the EHR versus I should use a Redox or a Rhapsody or which I think Redox and Rhapsody to me are very different. I'd love to hear, how do you kind of work through that? Maybe that's what you do at HTD Health.
Yeah, HTD, we help people navigate that and build the last mile, right? Like if you have a Redox, we're close with Redox, or you have Vim, we're close with Vim, or all these vendors, HealthJump, whoever, we build that last mile to build it into the right application, help them navigate that. I think it comes down to if I have to like, there's a whole web of complexity, but if I look at my spread of EHRs for my customer base and I say, shit, I gotta build a lot all at once, then probably a middleware vendor and a managed service vendor like Redox, like Rhapsody managed services, right? They have many product lines. They have like an interface engine, a do it yourself. They have a managed service.
Okay.
Um, maybe it's Lineate. I'm mixing up their product lines, but
Well, they have Rhapsody, Lineate, CorePoint, and yeah,
yeah. One
yeah.
of them is
They'll help you one way or
yeah,
another.
one's a managed service, and or Health Jump or whoever, like that can help you scale across EHRs, very quickly and concurrently. And so like that slots in pretty well, and that's usually a trigger to look at those. If your mix is pretty high end EHRs, Epic, Cerner, Meditech, Athena, then you'll look at sort of the Redox and the Lineate/Rhapsody. If you're looking more, you know, smaller doc practices, mid-tier EHRs, you might look at like a Health Jump or a Vim is roughly. If you're looking at dental, you can look at Next Health. That's the breakdown there. Um, if you look and you say, hey, I'm just doing Epic, I'm just doing Cerner, I'm just doing Athena, there's leverage to not having the middleman in the sense that you can build deeper, right? Because like all of these managed services, they're going to say, we're going to make it a unified data model. We're going to make it so you have one API. And that is amazing when you have a simple workflow that can be genericized. But if you need to pull the super custom Athena data point or like use a proprietary Epic API or whatever, then you'll have to do that probably outside of those pathways. And so you don't have to choose one or the other. You can do many. And over time, the best and most successful companies that have the deepest integrations do. They choose the right tool for the right purpose at the right time.
Well, and they may start with a Redox to connect to them all, and then they're like, wait, we have 100 Epic customers. Let's dive deeper, and, and then the cost perspective comes in.
Also, like Redox will help you get that MVI much quicker. So if you say I need to get to minimum viable integration and I need to do it across a number of EHRs or a number of sites concurrently, okay, like your minimum viable integration can be accomplished with the Redox APIs.
Sure.
But when you want to get super deep and like pull from Clarity or Cogito and use a proprietary API, then the Redox and the Lineates and stuff are going to be, that's just like not how they do things. Like I love Redox to death and I love all these companies. They are all close and babies of mine in different ways. And so,
For
and
sure.
so but like that reality of the choice of tool is that none of them are comprehensively, they serve every type of integration better than anything else. And like just like anything, if they
Mhm.
did, they would be the only vendor in the space. They would have won. And so the fact of the matter is that there are myriad vendors that do things in different ways, right? Like there's three main ways to connect to an EHR.
Okay.
Sanctioned interfaces. So these are APIs, HL7, X12, anything, any inputs and outputs that the EHR vendor has invested in to push data out, to allow data to be pulled out, or to push back in. Those sanctioned interfaces, those APIs, that's what we think of as integration. Those exist and many vendors plug into them, like Redox plugs into all of those, and so does like Rhapsody and things like that. But there are other ways of getting the job done. And so you see that with and they're just drawbacks and trade-offs to choosing them. So you have RPA, you have screen scraping, and this for SaaS mid-tier EHRs is very popular. You make a Chrome extension, you can scrape data from Athena or eClinicalWorks or whatever, and the job to be done of integration can be cheaper, faster, easier. It can break. So the trade-off is that breaks, that they change the UI or they do um,
Captchas on
CAPTCHA,
it.
they're unsolvable CAPTCHAs like we see with point-click care and real-time medical system. So a little cat and mouse because it's resented, right? Like the EHR wants to control what inputs and outputs there are. It wants to make sure that for performance or security or for monetization, like depending on how cynical you are, which piece of what their motives are, probably a bit of both. Um, and so that's one, like it's not sanctioned, it's not approved, but it can get the job done. And the
Mhm.
other third way is direct to a database, right? The back end of software. You can connect in some fashion. In some EHRs, that's easy. It's trivial. You just go and like, use a SQL adapter of some kind and connect. And others like Epic or larger EHRs might be quite hard. You might need to use their own API for that, right? Like Epic has pushed people away from connecting directly to Clarity, their reporting database,
Mhm.
towards Kit, which is Cogito is their normalized data warehouse. Kit is the ape set of APIs to run SQL scripts against it. They want you to use that. And that can get the job done potentially, but you're paying them and you can pay them quite a lot. That can scale up to where what should be simple, you know, analytics use cases for MIPS or quality measures reporting you become unfeasibly high because you need to really run them every hour or whatever. And so like Epic in particular has some vulnerabilities there in how they've done this and isn't particularly strong in allowing analytics integrations because of that. And so But direct to database holistically, if bubbling back up, is one of the three methods. Direct to database, RPA slash scraping, or sanctioned interfaces.
Yeah. It's interesting to look at it even just from different use case perspectives. Like imagine an ambient clinical voice vendor using a third party. It just doesn't work, right? The deepness of the integration that they're going to need, I believe, to be successful. Anyway, it's interesting. But you bring up the cost point. I want to dive into the cost a little bit more because it's a tricky thing, and your old boss Jonathan Bush, I think at one point said, "I don't want to monetize on the exchange of data, right? Like there's other ways for us to compete and to do it, although I think the more disruption, please, and their marketplace efforts have been probably monetarily very good for them. How do you see like where are people charging and how does that play in also with what was it, the information blocking rule that allowed for some charging via APIs fees and things like that. I think that was all in the same rule if I remember right. There's so many, but like how do you see this charging for interoperability, whether any of those three options that you describe? How does that progress, and does this become a business center for the EHR vendors? It feels like it's going to me.
Oh, it's like the question of our time beyond just healthcare, right? Like Apple and the App Store and the lawsuits both domestically and abroad. Like how do platforms charge and control? Is it rent seeking? How do we limit it? If we limit it, are we limiting? Are we is it capitalism anymore? Right? Like there's all these like deep fundamental questions that apply really blanket across industries, and we don't. No one has a good answer. No one has figured it out.
Brendan, I
And
thought you had
so,
all the answers. That's why we had you on.
yeah, no, I mean, nobody's figured it out. But so, but like in healthcare, what we can say definitively in healthcare is that we have a unique set of regulations that affect this. And information blocking, in particular, has the pricing exception and says how you can price. So and Epic, notably, and some others push back on that to say in the commentary period of the Cures Act ONC rule to say, like, whoa, you're shaping market dynamics here, and they're correct, right? Like the ability to charge, like in the era before Cures, you could charge on a revenue share, which is just like you can debate it all you want, but like is pretty ubiquitous across industries. Um, and you see in the App Store and things like that for iOS and Google. And so with information blocking, it becomes much more difficult to make that case that revenue share um, is correlated to like the work effort by the certified technology vendor. And so you see this shift by a lot of them away from revenue share for the core APIs and the core program towards transactional based pricing because the narrative is much easier to say, well, every time you're calling my API, there's errors, there's work, there's data generated. So much more easily correlates with work on the EHR vendor. Um, and so it just overall though that shift limits the upside of API programs. And so you see some EHR vendors sort of pulling back from offering services, also because of information blocking. So notably Epic, because Epic I'm deepest with, had App Orchard. And App Orchard has a revenue share. And App Orchard, you get a dedicated technical service and they would build these packages to make deployment of your app easier called uh, shoot, what are they called? It'll come to me. But they would build setups and support guides, and they'd build like this programmatic way to deploy build into the customer environment. Uh, and then information blocking happens, and perhaps some politics internally, who knows? And they retract and they close that program. They wait a couple months or a year, and they launch vendor services and the showroom and all that stuff. But like showroom and connection hub, that's like we can dig into it, but it's kind of smokescreen for really what's happened is a removal of most of the services of App Orchard. You no longer have a dedicated technical service member, so you can't, you have this list serve you send questions to. You no longer have discoverability of the APIs, the proprietary APIs or the kit like APIs and data schema that you used to have under App Orchard. So you can't really figure out what you can do or can't do. You have to submit a form that goes off into the void and you get an answer back. And you might get a different answer than the app next to you who has the same use case, depending on which TS is answering. You have a developer forum, but it's kind of a ghost town. Not a ton of people doing much there. You don't have a sandbox that you never did, but you only have this test harness, but other EHRs do offer that.
Mhm.
And so, why is this all happening? If you're cynical or you believe in nefarious purposes, it's like anti-competitive. And like I think Epic needs to be wary of that in the current landscape where the door has been open to antitrust. And so anti-competitive behaviors, particularly in app ecosystems, are a vulnerability that they
I
need
think
to
the
take.
trouble along, there is the competitive stuff and the monopolistic, stuff, which I don't think, we maybe we'll get into later on the particle health stuff. But to me, as an ignorant person, right? But you might look at it and say, what you just described there sounds like information blocking to me. Now, information blocking has become a legal term, and so I think that's the trouble. And we're not lawyers, so I don't think we need to dive into like, is this considered information blocking or not? But to the layperson, which is probably why they called it information blocking, is the layperson. It's like, it sounds like you're blocking them from being able to integrate the way that they want, right? Like that it feels that way in the I think you described the particle one. It's going to be judged in the court of PR, right? and perception before it's judged actually in the legal courts. And that feels like it to me. And maybe it's just part of the iteration and they're going to come through on the other end because they had to revise it. But yeah, anyway, I mean, is
I
that
ex-
information blocking or yeah, I
I
don't know.
expect I can't say if it is or isn't without looking at the specific use cases, right?
Or
Like it really comes down to details, but there's risk of it for sure, for sure. If I'm submitting an app and you're submitting an app and I get back a different API that allows your app to be more successful, that is the restricting the flow of EHI in an inverse way. And so I think there's risks there. I want to talk about risks, not who's right or wrong. There's risk to Epic with this policy, but it comes from a fear of information blocking, is my hypothesis here. And this is where it gets weird, is that in the app orchard, you were paying, and as a result of paying, you were gaining access to different APIs and in a revenue share model, and you're getting a lot of support. And so, like if I'm creating the turbocharger package, that's what it's called, for one app and not the other, then maybe you're restricting EHI. So I think that they were like, oh shit, like this is so one, they felt the burden that every developer company feels, which is people, small startups that have no funding come and add drag and like really hurt your ability to do anything meaningful with the most important customers because they're asking a bunch of stupid questions about what can I do with this API and what does it do and what is the Epic data model, what is blah blah. And so you have all this drag. And I worked at Redox, at Zeus Health, at Flexpa, at, three API companies and API forward companies. You always have this moment where you're like, man, I want to help startups. I want to help the smallest of the small, but it's really, really challenging from an operational standpoint to have the level of support that you need to educate them to get to like a baseline, to get to like just to understand. And they become tremendous drag on your business, and almost none of them actually survive, or they go and do something else. And so, like, I don't want to, like, I want to help them. And I think most developer programs want to help them, but like it is just a common pattern of being like, oh shit, like how do I handle this? I think Epic had that and looks and goes, well, we can't cut them off, right? Like we can't not support them because of information blocking. So shit, we got to lower the level of support that we offer significantly so that they have some resources, they have the developer forum to crowdsource stuff, and like, over time, if they're really, really big, and they want to move up, we have these toolbox program and we have the workshop program that are again back to revenue share. But for that, it's because it's not the baseline. You're opting into that. You're opting for this super high level of service. And then you have to be within specific use cases, right? Toolbox, you need to be specific blueprints where you can't join. Workshop, you shouldn't even be asking because Epic's going to come to you. You can't get in there. It's like is the thing I tell people because they're like, how do I get partnership with Epic? I'm like, okay, like go
Giga
look.
bait. Be great, and they'll come and want you to be there.
They care about, and get back to your customer focus thing, right? Like, what do they care about? They care about intellectual property and their customers. And their customers, if you have 15 of their customers or 100 of their customers, they're going to care a lot more about you
Yeah.
than they're going to actually want to talk. Like, they're not from a partnership standpoint, but like, like they're going to make it work for their customers and not have a bunch of inefficiencies. And they're not unique in that.
Yeah.
Like, that's an alignment of interest when you have mutual customers, your talk desk or your bridge, right? Like those are companies that had tons of customers. Epic goes like, let's co-develop because we're not going to go do what you're doing, and we need to have this be a superlative experience for our customers. It was
Well,
very
and I've seen them play out that like, hey, we want to do this with two, but then we're going to use that learning to open it up to the other 10 that are, in that space as well, right? I think that's what Epic's done over and over.
right, exactly. And so like one thing people miss is that a bridge and DAX and talk desk and all these things like they're co-developing, and that gives them a head start, and it gives them a distribution business from that head start and the marketing of being in that position for sure. But it is undeniable information blocking if the APIs and capabilities developed as a result of that are not made available to competitors. So if I'm Nabla or I'm DeepScribe or whoever, and I know there's APIs or functionalities that Epic has done and has made live with a bridge or another competitor and has not made available to me, that's when you email the TS listserv and say, hey, I'd like access to this because it feels like a little bit of information blocking. If you don't get it, you go and submit that information blocking complaint.
Yeah.
And that is the reality of information blocking is that they need to be making those available. They can negotiate on price, they can negotiate on various things, but if they make it unavailable, then they're
Yes.
information blocking. And by making that, people are afraid of it. In the B2B sense, people are afraid of information blocking. There's been a ton of submissions by patients,
Mm.
saying, hey, I can't get access to my data and using the information blocking route. That's great, but HIPAA already had that. And so it's just like a bigger fine and things like that. B2B, there haven't been very many. It's because people see it as like a lawsuit or like a really scary thing. And it's not intended to be. It's intended to be just reporting to the HHS when there's information blocking in order to investigate and resolve it. And if a certified health IT vendor or provider or health information network is information blocking and further restricts the flow of EHI by breaking things off or acting in an adversarial way as a result of that, they've just dug the information blocking hole deeper. They've
Yeah.
blocked further. And so the actual reality is that information blocking, you can go back to some of my writing on the Substack about this, about cures. Like I did a whole write-up of HIPAA, cures, etc. And on cures, I'm like, I don't get information blocking. It feels like a cudgel. It feels like this really blunt object. I don't think it's going to do a whole lot. Like it doesn't do anything prescriptively.
Mhm.
Um, it feels really far off. Whereas like I'm always into like the new APIs and new capabilities that are deployed at scale because of regulation. That's very clear to understand and to parse out the implications of. Information blocking, I was bearish on. And I'm like, wait a minute, it's not about that. It's about having this cudgel. It's like, what's the Teddy Roosevelt saying? It's like, carry big stick. Speak softly and carry a big stick. It's like you have the big stick of information blocking, and what that does is it forces eClinical Works and Epic and any certified tech, as well as providers and health information networks, to take things a little bit more seriously than they would before, and cooperate a little bit more and act collaboratively in the best interest of typically a B2B relationship. So if you have a health system customer and you're not able to get the job done you want to, it's a new lever to pull that people should feel a little bit more enabled to pull.
Yeah. It's funny you say that. I actually felt the same about Tefka, so I want to go there in a minute, but I think we need a little lively conversation first. Break up this interoperability talk. All the nerds are into it, but you know, when I first met you, I think we first met at karaoke, which is ironic because you love karaoke. I got to hear about this love of karaoke, but then you said something to me, which I'll never forget. You're like, John, dude, I love weddings. I was like, what? You're like, dude, if you want me to get the party started at a wedding, I'm your guy. So tell me about this love of wedding. It's not really crashy, I guess. But
I
partying at weddings
and
and
I let
karaoke.
you down. I'm sorry, John, that I couldn't make it to your wedding, but the
Life
young
happens.
daughter in life got in the way. But yeah, I mean, I just love a wedding is a moment. And there's all this like cultural and religious things that we think of, but like for me, a wedding, and those are true and like valuable. But a wedding at its core is a moment, like one of the few moments in time to bring together everybody that someone cares about and just be like, these are my people, check them out, get to know each other. So I'm a big fan of that because I'm like, I like being around, like bigger crowds and like groups of people and community. Like community is really important to me. And weddings at their best are a distillation of that, where you just be like, oh yeah, how sweet is this? Like these are friends of John, or these are friends of Michael, or whatever, or Cindy. Like I think that's awesome. People take it as a burden. I think there is this burden as people are more spread out geographically, and the cost of weddings are the only thing that can compete with healthcare in terms of rising.
Yeah, what was it on Shark Tank? The guy's like, he's like, I love weddings and deaths because you're gonna spend whatever's needed, and you're not gonna ask questions.
There's no price ceiling. And like, yeah, let's get the government focused on this. This is out of control. My friend in the Netherlands, they got married before they moved back, and they flew people out because it was cheaper to have it in a castle in the Netherlands than it was to have a US wedding. It's like, next after we solve healthcare, let's solve the wedding industry and the cost spiraling there. But
That's fun. Yeah, it reminds me of Alex Fair. I don't know if you know. I always forget it's Far or Fair, but anyways, he's started MedStarter and now a VC investments guy. He was at Health one time. You would have loved this. If you were there, you would have been all into it. I think it's Health or Vibe. Anyway, we go to the dance floor and everyone's there with their drink, chilling, right? The vibe, right? And of course, it's some big name singer. He comes up to me and he credits me with it. It's all him. He comes up, he's like, John, we got to get this thing started. And next thing you know, he just starts jumping, and I start jumping too. And then next thing you know, the whole place is jumping and dancing, and you're just like, you need that person, right? That like that's you've seen the video of the one guy dancing and then everyone on the hill, right? It's that, right? I think that's what's beautiful. And you need someone like that at a wedding, right? Like you're the most valuable person at the wedding because you're going to be the one that starts it and lets them know, hey, we can have fun. We don't have to be stuck here.
every community, every network has their producers, their non-entities, the non-value creation, and then their detractors. And so like, yeah, my goal at every wedding is to at least be like I added and detracted, right? You don't want to be the drunkest girl at the party or anything like that. And so, but usually I'm the guy who's got like the tie limbo or like suspender limbo going or whatever. And yeah, I love a good time to spend time with, have good deep conversations at the weddings, dance a little bit, and yeah, enjoy some things out there. And karaoke is just another distillation of that people let it loose, and they can be good or they can be bad. The karaoke floor is equally accepting of all entrants.
That is interesting, right? Because it turns out the best karaokeers are those who sing amazing, right? You love when you see it and you're like, dude, I didn't know she had that, right? Like, or the worst, right? Like, if that's the problem. I'm a mid karaoke. I like to sing
Pick
from
your
the.
pick your lane, pick your lane,
That's the
John.
problem. I like to sing from the seats because I'm mid, right? Like I'm not amazing and I'm not awful. So then it's like it's all right,
Just by being there, you contribute. So yes, there's two poles, and I think the two poles are the glorious ones. I'm on the low end. My sister Bridget Keeler is on the high end. Like she'll just rock it. And so we did karaoke at HTD. We had a team retreat in New York. My sister lives there. She met up with us, and the whole HD team got to see both poles by Keelers.
Well, like you said, at Health, hopefully we get this out before Health, but at Health, I've already got some people planning for some karaoke at Ellis Island. They do it every night. You've been there. It's a unique environment. You get to see. I love it. You know what I love about this place, especially because they do it every night in Las Vegas, is you see like this spectrum of culture. Like I remember this young 20-something girl got up on stage, killed it, and she's coming off stage high-fiving this 70-year-old cowboy who, it's saying to, right? And it's like, where else do you see that? It's beautiful, right? So
I mean, Vegas, the melting pot. I mean, that's what it's all about. Yeah, no, I mean, yeah, exactly, right? And when I lived in San Francisco, there was a glorious karaoke bar right between the Mission and well, shoot, I forget the other name of the neighborhood, but exactly that. There's like the dusty regular who's like 90, and you're like, how do you have this glorious voice? And then, the drunk crowd rolls in or whatever. And so karaoke is a mixing pot for sure.
yeah. Well, and during events you get the corporate people. Yeah, it's just awesome. Well, let's say I hit the networks, right? I think QHINs, Tefka. Yeah, as I mentioned, I remember Shahid Shah saying, John, you need to really look at Tefka. It's going to do more than you think. And I was like, it has no teeth. It has no like, what do you mean? And I finally heard, I attribute the success of Tefka and QHINs to Mickey. Like Mickey went in there and realized, hey, I don't have teeth. So there's no enforcement mechanism here. And I heard him describe it at the Direct Trust conference. He's like, we had to go in and figure out the business case. And in some ways that was good because then it forced us to understand the business that would make this make sense. He's like, and that's why the QHINs have been successful is because we went and figured out the business case. And they asked him, do you wish it had money? He's like, he kind of hedged. He's like, there's pros and cons, right, to having money. But anyway, what is your perspective on QHINs and the impact that they're going to have on interoperability? Let's say a couple years from now, right? We know they're still rolling out, they're still getting adoption. And is there a number of scenarios of how it could play out depending on, it feels like it's depending on the participation of the EHR vendors, but yeah, how do you see, what are the scenarios you see playing out potentially with QHINs?
Yeah, let's zoom back a little bit. QHINs, TEFCA, what is the interoperability problem to be solved? The core one is clinical data exchange for treatment purpose of use. That is a semi-solved problem, right? Like we have care equality, Commonwealth, e-health exchange that allow for exchange for that purpose for transfer of care in emergent care and all these different types of care
Yep.
for 70% of providers and growing. And so this in the spectrum of that interoperability we started with is like semi-solved, right? Like that's pretty good. Like why are we replacing it with a government funded entity or like like government sponsored entity, right? Like there's some of that vibe going on. The thing is that Tefka allows for a broader set of use cases that these existing networks have struggled to build. They've struggled. Networks are hard to build. Upgrading a network is hard, right? You see the move from 2G to 3G to 4G, huge capital expenses by telecom, and they don't have like an
I was gonna
adoption
say there's
mechanism.
5 of them. Like,
Yeah, like they have to spend a ton of capital, but they can just say, oh, it's on, and people use that capability. Whereas with care quality, with Commonwealth, with these nationwide networks, they want to have new use cases and new capabilities, and they've made implementation guides, but they've lacked levers to get people to adopt them, and they've lacked incentives to get people to adopt them. And that means we're stuck, right? Like we've been stuck on just treatment purpose of use pull of clinical data for a long time. While the network has grown, that's great, but like we want other things. We want event notifications that are ubiquitous across all of America and not geo-fenced by our using point click cares, collective medicals network or, Bamboo Health's network or a state HIE's network. Ideally, you want ubiquitous national infrastructure solutions. And so
and so
all the
why couldn't you do that on the Commonwealth Care Quality eHealth Exchange? Like it would just wasn't the business model, or is
to be supported, has to be technically supported, right? Like there's each node on the network needs to build that new capability. So you're not just you're creating a net new network with a similar with like you have the advantages of some buy-in because
yeah,
people are on it,
there's some
uh,
trust, the
some
entity.
trust and some things like that. But you saw a struggle to adopt to adopt new features to level up Um, Even though they created new implementation guides that would have been really awesome for image exchange and publish pub sub, so subscription and publication of event notifications. Um, yeah, a ton of other cool stuff. And there are ways to do that in the private industry, right? Like Visa and things like that. You see them upgrade their network and add new features, and they're kind of more forceful about it. And for a variety of reasons, care quality, Commonwealth, et cetera, have lacked the levers or lacked the structure, the governance structure to make those changes and pull people forward and say, hey, we're going to cut you off if you don't add something new, right? Like that's a semi-nuclear option, but you see networks do things like that. TEFCA gives, through a variety of reasons, the ability to move things forward, to broaden use cases, to broaden capability sets. So immediately moving to TEFCA, we see the ability to pull and to push. And previously, these were separate, disparate networks. So you had Direct Trust, then you had, what you went to the conference, the Direct Trust conference, right? Right. And like now Direct Trust is doing a lot of work with Care Quality and Commonwealth because unifying that infrastructure and capability set over a single directory and things like that is really advantageous for workflows. You see individual access as a net new use case built into TEFCA, so patients can access their information. And you see them working and trying to get the operations use case for payers to exchange with providers back and forth. And so new capabilities, levers to upgrade and get new capabilities out on the network and digitize more workflows than just the one that we had. That's the promise of TEFCA. I was super bearish, just like you, on TEFCA until the spring. Well, actually, super bearish from Cures Act being passed until Biden admin, because the Trump admin did not like TEFCA, like or did not work on it very much. Right? It was supposed to be done or ready to go in 2 years. So 2018 didn't really happen. To your point, Mickey comes in and pushes it, right? And the government, the ONC at the time, now the STP, pushes the boulder forward and push the boulder forward for 3 long years, and others help, right? Like a few other people get on board, but in paper, on name only, they announce the network, but like it's not going, and it's not for certain at that point that it will happen, right? There's this whole meme from Lisa Bari and Kat McDavitt that's like, is TEFCA real? Like, are birds real? And like that era that was valid to wonder that, because you could imagine a world where coming into election cycle, right? It's 2023 and you're projecting a year out and you're like, shit, like there's an election cycle. And if a Trump admin comes back in, they could stop pushing the boulder. They could push back on the boulder, right? Like you don't know. The world is, the path forward. It's the multiverse of possibility. But looking at prior art, they could at least let it stagnate and not progress. And private industry was not ready to shoulder that burden at the time.
Mm.
The spring happens, and we have the Epic and Particle dispute, separate from the lawsuit that we just had, and that is a catalyst for people to go, oh shit, this pent up demand for other use cases is being underserved by the market. Private industry can't get their shit together to solve these other workflows. And so we see entities piggybacking on a workflow designed just for treatment and using it in a way that is, um, legal, right? Potentially legal, depends. Potentially in law, according to the network rules, potentially, but not the way we want it to be done, in the sense that not transparent, not an equal exchange, asymmetric in terms of how it operates. And the beauty of Care Quality, Commonwealth, the networks when they were solving for treatment, is it was symmetric. You can come and have this amazing capability as a provider to pull data and use it at the point of care, use it for other things, use it for treatment, other treatment uses, if you contribute your data back. Reciprocity. That power is fueled the growth of the network. Reciprocity was really hard to get people on board with. Once you lean into it, it allows for symmetric relationships. And that's really powerful to build a longitudinal patient record, which is the goal. And so as we start to see asymmetric relationships grow by the use of the gray area, use of the secondary use, to serve underserved use cases, the payer use case, law firms looking to do mass tort, individuals wanting to access their data, people piggybacking on this network put stresses on it such that a bunch of people said, a bunch of Epic and Meditech and a bunch of EHR said, oh shit, we don't want this to be the future. So let's get our shit together. And so they start to push. And I see private industry pushing on TEFCA in a way in the past 4 months, 5 months, well beyond, like, way harder, way more progress than we've seen in the 3 years before, in the 4 years before that. And so the ball has started to roll such that Epic has announced their full transition plan, saying we are going to get everyone on board by the end of the year. We get all of our customers converted by the end of next year. Meditech did the same 2 weeks ago. Athena has said they're going to start moving people over. They have at least one site live. And so you start to see private industry shouldering the burden. And I think there may be other announcements to come because we have the Commonwealth Conference, the Care Quality Conference, and the ONC Forum all this spring and fall, or fall and winter.
Yeah. Well, and Oracle Health's about to announce their new EHR, so they're a little distracted by that, I think. And then
When you do a full replatform,
they got a little bit to do before they address interoperability, although I'm sure there's a couple of people working on it that are like, why don't you shout this? And they're like, we got other fish to fry.
I think it could be at Health, could be at Health, could be at Commonwealth, could be. I have no crystal ball
Could
inside
be
of
at
that.
their event, the
Yeah.
Oracle Summit. That's going to be an interesting one to watch for sure. You know, it's interesting how you describe the use cases. Talk to us a little bit more about that, right? The treatment use case, I think we understand because that was actually part of it. I mean, I remember that early meeting when I knew nothing about healthcare. I'm a tech guy getting hired into practice, and they were talking about sending the information to another doctor that they referred to. And we had to dive into that HIPAA and we're like, oh yeah, that's allowed. You don't need permission. You don't have to go get the patient. It's like that's part of the care process and the treatment, and it's allowed, right? Which to me feels like the treatment use case is leveraging that, right? It was like, yeah, we're sharing data because it's better for the patient, and this makes a lot of sense, right? Obviously, we've seen some people trying to abuse that in different ways, but what are how do you see in the QHINs the different use cases? What do you see as, outside of treatment, what other use cases need to be kind of refined and put out? My favorite is the public health one, which I think, Mickey is pushing forward in a way that's really beautiful and deservedly got renamed to ASTP, not because I care about names or need 4 more letters in my life, but he is essentially an assistant secretary with with hopefully more power and oversight to be able to, leverage QHINs for public health reporting. I love that, right? It feels like he's pushing that forward in a big way.
Yeah. So talking about use cases, it goes back to where we started about breaking apart interoperability. People are like, oh, sharing data. Why aren't we sharing data for, like, it's not about sharing data. It's about solving workflows. And the initial networks, the goal was you can actually look, if you look at the standard that underpins these networks, continuity of care document is a document that summarizes the patient, not all the data, but just says, like, what do I need to get over to Dr. Smith when Dr. Smith has seen you in the ER because you've been hit by a bus. And so when you look in that lens, it was meant to solve the continuity of care as patients move between providers. And so as we start to think and say, okay, it's shifted, like, people forget that history and baggage, and maybe they should, because it's like, oh, now we're sharing data and pooling data. And they start to think of, like, all the de-identified networks of, like, data sales and all that crap. And it's like, no, no, no. It's like we have workflows. We have workflows as entities, as care or financial responsibility shift between different players. And how do we transfer what's needed? How we accomplish that workflow is what's important. And the thing is, if you squint between several workflows, they look pretty similar. The pull of data when you're hit by a bus and you pull from Dr. Smith or from Dr. Steve and you're Dr. Smith is not that different than a payer when they need to do HEDIS reporting or care management or quality measures. They need to pull clinical data. And so people squint, or law firms need to, when with patient consent, pull data for legal proceedings, mass tort. So you look at the capability set made available to solve a certain workflow, and you say, ooh, I'm squinting and it looks the same. Let me just use it. And I don't think that's necessarily wrong to say we should be able to use this and serve other use cases and not do it really manually and expensively. But as a collaborative community, as a group of very different parties all participating and trusting one another, that the relationship will be symmetric and that others will not abuse my trust to the detriment of my business and my patients, that that squinting needs to be an open discussion, is what people are saying. It needs to be defined about how we do this rather than taking advantage of one another, is the thesis, right? I think that the use cases that are being served by piggybacking on treatment are intended to solve problems that need to be solved. And if they end up being cemented by judicial proceedings or by just usage as the path we get to that outcome, so be it. We've digitized these workflows. It would not be ideal. And so if I just think from a very pragmatic standpoint of, I bias towards solving these in ways that enable transparency, that enable reciprocity to grow the network, that contribute to a shared longitudinal record, and have symmetric relationships in the sense that if I'm a payer and I'm communicating and I want to pull clinical data, if I do this in a dark pattern, if I do this in through secondary use and these other patterns, then it is an asymmetric relationship that will inevitably sort of piss off the people I'm pulling from, because you are pulling in a way that is one-sided. If I am participating in a way that I contribute back claims data and initiate are participating as equal participants or as equal as possible, contributing back care gaps, like solving other workflows, right? Because not only is it just I need to pull clinical data for HEDIS, but I need to say back to the provider, hey, you're missing these things. And with the paved paths, with the approach where we say we're going to solve each of these workflows and adopt them, we gain the leverage of shared longitudinal record, symmetric relationships, higher trust, better transparency, and more fully solved workflows end to end. That's my optimism, is that um, we can get to a place where we solve workflows in a design pattern, in a collaborative pattern, versus an adversarial asymmetric pattern, because the erosion of trust may cause people to, like, networks are notoriously sticky, but they can be destroyed by destruction of trust, by pollutants, by people that are the trolls on LinkedIn, or the guys who are cursing and saying and doing like degrading women on Twitter or something like that. Like, those people cause people to say, this is nice because there's a network effect of people that are like-minded, but man, I hate this experience. My trust is abused. I feel unsafe. All these negative reactions could cause people to exit networks or choose alternatives. And so that's a possibility over time if the networks become one of pure asymmetric relationships.
I think it's interesting your focus on asymmetric, which I think is problematic because interestingly with the payers, they do have something they could offer, right? Like, but like when you look at the lawyers, they don't, right? Like they only are in it for an asymmetric relationship from a data sharing standpoint. But I think what's interesting, okay, let's take that use case, which I know far too well because I've spent too much time at AHIMA and release of information stuff. And 50% of release of information are not patients requesting stuff, it's lawyers, right? Or payers, that are doing it. So if you look at it from a pure data sharing, they have nothing to offer. They really can't. But if you look at it from a use case for the provider organization, they do have something to offer, which is I'm going to stop bugging you and taking up 3 staff filling our release of information requests that get faxed over to me or whatever, right? Sent through some other third-party system. I'm going to solve that problem for you as a provider organization. So from a value standpoint, it's not asymmetric, right? The provider organizations would love to offload the release of information to payers and lawyers. And, whether they're giving more information back, they don't care, right? You're saving me staff time and the burden of trying to share the data. And so, that it's interesting that they could still be potentially good players to your point, in the network that aren't the ones degrading others and making us not want to be there and not trust the network. But then, I think in our minds, we look at it though and be like, yeah, but are the lawyers going to stay to that path? Or are they going to just start scraping all of the data off of anyone that fits this little use case so that I can file 10 more lawsuits based on pulling the data? Like, isn't that the fear of bad actors like that?
When you build networks, your innate reaction is, oh shit, how can this be abused? So when the networks for treatment started, we had this exact reaction. Oh, my fiercest rival down the street can pull my data.
Yeah.
My provider organization will pull my data. And
Yeah.
we've gotten over that hump because we've seen the benefits, right? And so by doing it in as symmetric as possible, like the symmetry here is by doing it via clear patient consent that is shared back, right? Like if I do the individual access path to share with lawyers or with whomever, non-HIPAA entities, then I have clear documentation of consent, clear visibility, clear control by the patient, which is now not clear. It's asserted, right? Like you can talk to these other groups that are doing using the secondary path, use path that are doing law firms or pharma or whatever. They're like, oh, we have the HIPAA consent. Well, you don't engender trust when you don't have transparency. So by choosing the opaque way, we lose transparency and trust is eroded inevitably. And so all this to say, 100% your optimism is my optimism, which is these are use cases that need to be solved. The better pattern for long-term success is one that has transparency.
Yeah, that's a good way to describe it.